I am Valentin Fuster from New York. I'm sorry, I'm not from New York actually. I was born in Barcelona. And I'm very proud to be here today as part of the European Society of Cardiology meeting in this beautiful city. And it is a pleasure to actually chair this session, 1 hour session, and discuss the excitements that we have seen in this meeting with 4 luminaries that I have here with me. And I'm going to start with my left. Dr. Barbara Casadei is a British Heart Foundation Professor of Cardiovascular Medicine at the University of Oxford, and she's the President-elect of the European Society of Cardiology. On the left is Dr. Borja Ibáñez, who is the Director of Clinical Research of the National Center of Cardiovascular Investigation in Madrid, or CINIC. And here we have Dr. Deepak Bhatt, Executive Director of Interventional Cardiology at the Brigham and Women's Hospital in Boston. He's a usual on this program. And here we have a good person from Germany, from München, a professor of cardiology, Dr. Adnan Kastrati from the Deutsches Herzstratum. Is this okay?
Herzzentrum.
Okay, I'm sorry, we'll try again next time. Thank you very much for being here with us. We are going to have a good time, and we are going to be really discussing 8 subjects. So let's not get nervous. We'll go step by step, and I will tell you what the subjects are so people know how we are going to approach it. The first subject will be on a stable coronary disease, the CANTOS trial about anti-inflammatory medication. The second about stable coronary disease, the same type of anti-inflammatory medication, but what it does for cancer of the lung. Quite of a surprising situation. Then we have a third topic, which is a stable coronary artery disease, but in this case we are getting into the antithrombotic therapy, the COMPASS study, the use of low-dose rivaroxaban with aspirin. And then we go into acute coronary syndromes, the VALIDATE study by bilirubin versus heparin. I've heard this for the last 10 years. Let's see if we get an answer today in these patients with acute coronary artery disease, acute syndromes. And then how not? We have to move into atrial fibrillation. If atrial fibrillation is not discussed, something is wrong, isn't it? So we have to get into atrial fibrillation. The 2 topics being presented here, one is the dual PCI study, dabigatran and aspirin on patients with atrial fibrillation and PCI. Let's see what the study showed. And the other is in the acute stage of atrial fibrillation with cardioversion. The EMANATE study is apixaban as good as oral anticoagulants, conventional anticoagulants, to prevent a stroke in the first few hours of myocardial infarction as the patient undergoes cardioversion. Well, we have coronary disease, and now we have atrial fibrillation, but there are other subjects. What about hypertension? What about if we get again into the sympathetic system? You were the PI on the previous study. Are you converted?
Fair question.
Let's just wait.
Oh, okay.
Let's just wait.
Good, I can think of what my answer.
Oh, you will see, you will see. There's a lot to be discussed here. And the next issue is, I learned as medical student I should give oxygen to any patient that comes to the CCU with a myocardial infarction. Even is in the guidelines. He just came out, he's the chairman of the guidelines of the European Society of Myocardial Infarction. He will tell us later what you say about oxygen, whether it fits with what was found here or not. So, let's start. Let's go then to the first theme everybody's talking about. Is the issue of inflammation in coronary artery disease. Well, I think it has been known for a long time that coronary artery disease, in a way, is an inflammatory process. Is not only the C-reactive protein may be elevated, but we know when we treat, for example, patients with statins, it seems that we are also addressing, aside of the cholesterol, we are addressing the macrophages and other cells that are inflammatory cells, and even the thrombotic process. Well, over the last few years, it has been found that at the moment that cholesterol deposits in the vessel wall, in the chronic disease as well as in the acute coronary syndromes, there is an inflammatory process that takes place, and it probably is a defense mechanism. The cholesterol of the vessel wall calls the bone marrow, calls the spleen, macrophages move into the arterial wall, and we have two types of macrophages. One macrophage is a healer, and that is connective tissue synthesis, takes care of the artery, and the other is really betrays you, is a very aggressive, clears the artery when there is an acute coronary syndrome, and this is another type of macrophage. Well, all of these back and forth between the arterial wall and the bone marrow and the spleen has intermediaries. Some of them are the interleukins, and this is actually the one that we are going to be talking in a moment. And there is a drug called canakinumab. I do right? We'll learn after a while, I think. Canakinumab is an anti-inflammatory drug that actually blocks the pathway of interleukin-6 with the so-called interleukin-1 beta. And this drug has been tried to see in patients with chronic coronary artery disease, patients who already had a myocardial infarction, to see if good things may happen by blocking the inflammatory process that I described. So the authors had a randomized double-blind study with this monoclonal antibody involving actually 10,000 patients, as I mentioned, with previous myocardial infarction, and they had to have a high sensitive CRP of more than 2 milligrams, just to say that there is an inflammatory process. The trial compared 3 doses of canakinumab, 50 milligrams, 150 milligrams, and 300 milligrams. And this drug was administered subcutaneously every 3 months and was compared with placebo. Now is the important point. What about the primary efficacy endpoint? Was non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. At 48 months of follow-up, the median reduction from baseline in the high sensitive C-reactive protein was 26% in the patients with the low dose, was 37% in the intermediate dose of the drug, and 41% in the high dose of 300 milligrams. So CRP is affected. So something goes on with the inflammatory process when the drug is being given. And now let's discuss the results. Median follow-up, 3.7 years. The incidence rate for the primary endpoint, I repeat, non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. Here is what happened with the placebo. 4.5 events per 100 person years. This is the placebo group. Then it went into 4.11 events per 100 patient years in the 50 milligrams group, 3.86% in the 150 milligrams group, and 3.9 events per 100 patient years in the 300 milligram group. So really what we have is important is a placebo group with 4.5 events per 100 patients years. And here you have the highest dose, 3.9 events per 100 patient years. And here we run into an issue. Are we talking about a relative decrease in events or an absolute? The absolute is very little, frankly. And the relative maybe close to 20%. I don't know exactly what it is. But I think what is interesting, and we'll discuss in a moment, why the best dose was 150 milligrams rather than the 300. But that's really a finding. In addition, there was some incidence of fatal infection, and there was no difference in all-cause mortality between the placebo and the treated group. So here we have the conclusion. According to the authors, anti-inflammatory therapy targeting the interleukin-1 beta innate immunity pathway with canakinumab at a dose of 150 milligrams every 3 months led to a significantly lower rate of recurrent cardiovascular events than placebo, independently of lipid level lowering, which actually didn't change much. Well, this is the CANTOS study. Okay, my friend, Deepak, what do you think? Just give me a capsule report. What is going on in your insight?
Sure. I think the trial is really important because it validates the whole inflammation hypothesis in atherosclerosis. That is, there's great basic science supporting that, but now we've got a clinical trial that shows an agent that's specifically an anti-inflammatory reduces cardiovascular events. So we know statins reduce cardiovascular events, they reduce CRP, but they also reduce LDL. But here we have something not affecting lipids, specifically targeting a pathway in inflammation, and it significantly reduced ischemic events. So to me, scientifically speaking, it's huge because it completely validates what had been a really reasonable hypothesis, but up until now, a hypothesis. So,
well,
big
what
win.
you're saying is it validates a concept, which is the concept of inflammation. Many people may say, okay, I'm going to start treating my patient tomorrow. Well, the drug is available, but you need $200,000 to over a year to take this drug 3 times. And the question is also the issue of the impact of the drug that has in the overall rate. So we are in agreement that the concept is validated, and I think it's a great study. But how do you react to all of this?
I think I fully agree with Deepak. It's a very important study for confirming this hypothesis. And on the other side, the price will not stick to this high level, because if you think about the large number of patients with coronary artery disease, it may induce a reduction in the price. You have said that the numbers are very small, but they are calculated per 100 patients per year. And this kind of patients will be treated over a long period of time. That means that if you calculate per year, that will be over the long time, it will be an important reduction.
It's a good point.
Yeah.
Yeah. Okay, Barbara. So what happened? In Oxford, you analyze things very well. You have lots of trials, and here you have one that had a large impact in this meeting. What do you think?
This trial, I think that, again, it is important to have something that after so many studies in mice and so many hypotheses is actually testing it in humans. And the investigators need to be commended for that, because this is not an easy trial. I mean, we need to talk about infections. When we interfere with the interleukin-1 and 6 pathways, we increase the number of infection, the number of sepsis, and we have some death by sepsis here. So it is a kind of treatment that one would have to consider, keeping a very close eyes on the evolution of a minor infection in patients taking this treatment, as we already know from the rheumatoid arthritis world.
But that's not much different, really, than other stuff, right? I mean, you give an antithrombotic, it reduces ischemic events, but it causes bleeding. I mean, I think it's just a biological concept of there's no free lunch. I mean,
no,
anything that perturbs one system.
There is with
bad.
statins. So if the idea here is to say we lower the LDL cholesterol, and then we identify a group of people with a residual risk where we have already lowered the LDL cholesterol, which is more or less a free lunch, and we are selecting those with high CRP, an inflammatory response, and we tackle that particular angle.
But you're interfering with the immune system
Yes.
anyway, so this cannot go away. But I
Yes.
think what he's saying is that any drug that we give, we have to see both sides, but I agree. So Borja, tell me, what do you think about all of this? You just finished this document that came up yesterday about guidelines in myocardial infarction. Do you think you're going to have something like this next time?
I think we have to digest first. So I agree that conceptually this study is very important. And also one thing that I like a lot about this study is that you can predict which patients are going to benefit from this therapy, because the reduction of C-reactive protein at 3 months was predictive of reduction in events. So this is something that might be taken into consideration of which patients are you going to treat. So I think conceptually is very important. It validates something that we have been knowing from basic science for a long time. It might reduce cardiovascular, or it reduces cardiovascular events, mainly myocardial infarction. and also we can predict which patients are going to benefit from this therapy.
So in summary, the concept is good. It really validates the concept, and the authors of this paper and the investigators should all be congratulated. But this is time to get into the second finding that came about. I still don't know how it came about. The first paper that we have just discussed was published in the New England Journal of Medicine yesterday. The second was published actually at the same time in The Lancet, and it's a similar study. It's the same study basically, with the same methodology that we have described. And here what they are looking at is what happened with cancer. And because there is some preliminary information that this type of anti-inflammatory drugs can have some effect on cancer. So let's discuss this second observation, which here is quite striking actually what they found. So basically you know about the 10,000 patients with previous myocardial infarction. You know about the 3 dosages of the canakinumab that were given. I'm pronouncing better, isn't it, after a while? Thank you. And then the question is what they are looking at. Well, I will tell you that they look at 3 or 4 things that are quite interesting compared with the placebo. Cancer mortality in general, incidence of lung cancer mortality, fatal infections or sepsis that you're just mentioning, in all cause of mortality. So what were the results? In terms of cancer mortality, were 196 patients who developed cancer mortality out of the 10,000, and was significantly lower in the group with canakinumab. In fact, we have a hazard ratio of 0.4, which is quite good. And then they have into the incidence of lung cancer a hazard ratio of 0.6, and then particularly with the 300 milligrams, not the 150 that we saw before, here with the 300 milligrams, the higher dose, we have a fantastic result with a hazard ratio of 0.3 in terms of incidence of cancer. Then we have lung cancer mortality, and we are in the same ball game, hazard ratio of 0.23. Fatal infections, not trivial. And then the all-cause mortality in general, there was no difference between both groups. So here what we have is that the data suggests the possibility that anti-inflammatory therapy, this is what is written here, with canakinumab, targeting the interleukin-1 beta innate immune pathway, could significantly reduce incident lung cancer and lung cancer mortality. Replication of this data in formal settings of cancer screening and treatment is required. I'm going to ask you again, Deepak, because you have great experience with trials. This was not part of the study originally. This was an observation made during the study. So how confident you are of this data that comes out of the blue on something else that you're looking at?
Great question. I think, first of all, scientifically, it's extremely interesting. The atherosclerosis part of the trial was interesting. We were all hoping to see a reduction in MI. I personally wasn't aware of a relationship between anti-inflammatory therapy and potentially reducing cancer. But you know, I ran into Paul Ritger yesterday, and he told me that this was part and parcel of the trial. That is, he said, I wasn't aware of it, there's this whole biology about cancer and inflammation. So he went in hoping to see this. So it's not as out of the blue as it might seem to us, you know, as card-carrying cardiologists. And I think it's really interesting. You know, we'll see what the company does for the drug. This is a potentially very interesting application. It would need further study, and as the paper says, confirmation. But I think with respect to some of the work you do in global health in terms of risk factor reduction, this tells me that approaches that reduce inflammation, in this case, you know, an expensive drug, but other approaches that reduce inflammation, dietary, lifestyle interventions, more physical activity, that maybe olive oil, that these sort of things that reduce inflammation will reduce cardiovascular events and potentially cancer events. So to me, that's a huge finding with a lot of implications that go beyond the specific drug.
Sure, Barbara, is interesting. This data that came out in the last 6 months, which is fascinating, is, for example, the tobacco and the pollution, how you end up with free radicals in the lung, and it's an inflammatory process, and it's such inflammatory process that triggers lots of problems, cardiovascular, cancer, and so forth. And the other aspect is from Sloan Kettering is the issue of metastases. Metastases actually is a combination, of course, of the cancer cells, but it's a combination with monocytes, inflammatory cells, as well as platelets and so forth. So today we are getting a link between these two processes, cardiovascular and cancer. And what do you think?
I think to some extent it's a pity that the two papers were published separately, because you have to consider that these are, this is a treatment for patients who are at high risk, probably ex-smokers or current smokers, and with an inflammatory process. So you have an intervention that is catering for the global patients at high risk and reducing both a cancer that would be common, relatively common in this group of patients, as well as the cardiovascular events. So you have a global treatment for a particular type of patients.
It's fascinating, is indeed.
Yeah.
You have cigarette smoking affecting both, and now
Yes.
you are beginning to understand
Yes.
that the pathway is an inflammatory pathway,
Yes.
most likely.
Right.
Borja, what do you think about cardio-oncology?
Well,
Concept.
the concept is great. I think the
You
two
think it's
words are
coming?
really merged. It's coming. Not only in terms of cardiovascular complications of cancer therapy, but also with this one we can see that there are links also from the pathophysiology point of view. So again, conceptually this is very important. I don't know, I mean, there is a clear need for further studies, because I don't know what the oncologists are going to do with this data, but it's scientifically extremely interesting.
Adnan, you're an interventionalist, and today they talk about this heart team. You have the surgeons really watching what you are doing, or you watch the surgeons what they are doing. Now you are going to put an oncologist there too?
No, I didn't have the chance to dig in the data of this paper. I wonder whether it was a pre-specified analysis, this one, and why focused on lung cancer. Was it and the other types of cancers?
It was pre-specified, and that's because there is actually...
As a lung cancer?
Not really. Total mortalities in general of cancer, not necessarily lung, was one of the aspects. What happened is the most striking data came from the lung.
But
there's all the science
just to
actually
answer your
behind it.
question, we have enough to do with surgeons. I'm not going to call in also oncologists in our
Not
heart
yet.
teams. Not yet.
That's fine.
Yeah, but cardio-oncology is booming. I mean, I don't know the case in Europe, but in the US, every academic center either has or is recruiting a cardio-oncology person or
Absolutely.
team.
There are
so-
new sections being developed today all over the world, actually, also in Europe, of cardio-oncology as a field. And this is a clear example of how both fields are getting together. But anyway,
Radiotherapy as
very
well.
exciting, isn't it?
Yeah, and
both
for
papers.
radiotherapy of breast cancer
Right.
on the left, and the coronary disease that follows.
Yes, exactly
that.
true. Yeah.
Very interesting.
Well, anyway, we have a lot of work to do, and we are not doing too badly. So let's continue. So now we are going to move into also, still we are in the coronary arteries, chronic coronary artery disease, and this time we are going to talk about rivaroxaban with and without aspirin in a stable cardiovascular disease. I have to say, and you might remember, this is the first trial I got involved with after the bypass trial, was the CARS study. The CARS study, we had the concept that we would use aspirin, low-dose Coumadin, in order to prevent cardiovascular events. We did the study, and it was quite disappointing, because the first study we did with bypass grafting and aspirin worked. This second one was a real disaster, was no difference at all. So we left the concept of low-dose Coumadin, and now it's coming back through a different door. And I think this is fascinating. It's a very interesting study. This is the study was presented by Dr. Eichelboom. Is also published in New England Journal of Medicine, the COMPASS study under the leadership of Salim Yusuf and the group from McMaster University. So basically, you know the story. The story in coronary artery disease is interesting. Aspirin came up, and then when the studies were done together, aspirin and Coumadin was a little bit better, but was too cumbersome. And that's how Coumadin was left aside. Then we did what we did, tried to combine both, and it just didn't work. And meantime, rivaroxaban has been getting into the field with some data indicating that maybe it could be good in coronary artery disease in the aspects that we are going to be discussing, which is chronic. So there has been some preliminary data. And this is how the investigators here designed the study. COMPASS means cardiovascular outcomes for people using anticoagulation strategies. This was a trial, and they tested the hypothesis that rivaroxaban at a low dose in combination with aspirin or given alone was more effective than aspirin alone in preventing recurrent cardiovascular events in patients with a stable atherosclerotic disease, because there were also strokes in these patients that entered the study. So the study, these patients with 27,000 were randomized actually into the combination of very low dose rivaroxaban 2.5 milligrams twice daily. Actually, is interesting because we'll discuss a study in which with atrial fibrillation is also low dose, plus aspirin, rivaroxaban alone 5 milligrams twice daily, and aspirin 100 milligrams daily. So there were 3 arms in the study. And the primary outcome was the combination of death, stroke, or myocardial infarction. And the study was so good that it was stopped because of the superiority of the rivaroxaban plus aspirin group. So let's look what happened. Well, certainly when you look at the data, the primary outcome, and I repeat, we are talking about cardiovascular death, stroke, or myocardial infarction occur in fewer patients in the rivaroxaban plus aspirin group than in the aspirin alone group when you take this combination of these 2 arms, 4.1% versus 5.4%. We are again into a similar situation. You know, the difference is quite not large difference, but maybe on years of follow-up it becomes more significant. Of course, measure bleeding occur in more patients with the rivaroxaban plus aspirin group. But the overall results show that when you have the combination of aspirin with rivaroxaban 2.5 milligrams twice a day, the results are better by the percentages that I just commented on. The primary outcome did not occur in significantly fewer patients in the rivaroxaban alone group than in the aspirin alone group. So here there was no difference, except was a little bit more bleeding in the rivaroxaban group alone versus aspirin alone. So here we have the conclusions according to the investigators, and that is among patients with a stable atherosclerotic vascular disease, those assigned to rivaroxaban 2.5 milligrams twice daily plus aspirin had better cardiovascular outcomes and measure bleeding events than those assigned to aspirin alone. Rivaroxaban 5 milligrams twice daily alone did not result in better cardiovascular outcomes than aspirin, and perhaps with an increase in bleeding. So here we are, Borja. We are back now in patients with a stable coronary artery disease, and we are really talking about giving 2 drugs rather than 1. So what do you think?
Well, I think the results of this study are remarkable because not only the primary endpoint was significantly reduced, but all-cause mortality was significantly reduced. So I think this is one of the reasons why this study might have an important role. There were previous trials, Atlas 2 trial, in which patients early after acute coronary syndrome, they had a reduction in cardiovascular events, but this was at a cost of increased intracranial bleeding. But these patients were on dual antiplatelet therapy plus rivaroxaban, And in this case, these patients are more stable, much later after stenting, and there was not an increase in intracranial bleeding. So I think the results are remarkable, and compared to the studies that you were doing with low-dose warfarin, this study had 27,000 patients, which is really...
Yeah, large number of patients. Deepak, why you don't predict the future a little bit? Let's say in 5 years from now, we face these patients constantly with chronic coronary disease. Forget about the stents or no stents or dual antiplatelet therapy. You're facing here 2 drugs doing different things with results that are quite significant. So how do you see the future of this?
Yeah, I think that's a great question, though I do think dual antiplatelet therapy figures into it a little bit, because at least the patient who's had an acute coronary syndrome typically now is started on DAPT with or without a stent, and it's continued for at least 12 months. And after 12 months, the US, and now we find the European guidelines, give it a 2B recommendation to continue beyond that in select patients. So it might be having a role there too. But in the stable patient, the truly stable patient, as was included in this trial, and the peripheral artery disease patient, as was included in this trial, there the data look really good. I think the challenge is convincing a physician to take a patient who's sitting in the office, pretty comfortable, doing well, asymptomatic, and starting a therapy that is associated, with an excess in major bleeding. But the data, including the mortality finding, would suggest that that's probably the right thing to do.
The only question is the cost.
The cost is definitely an issue, but you did say a few years into the future,
Yeah.
at some point it'll go generic. So this concept, I think, could really take hold at that point.
Yeah,
The other point maybe is when to start it,
Right.
because this kind of patients might have been taking dual antiplatelet therapy for 6 months, for example. Are you starting them after 6 months, after 1 year?
Well, the trial can't directly address that because patients on dual antiplatelet therapy or a need for it, a perceived need, were excluded. So, I mean, there are still unanswered questions, and the editorial that Dr. Braunwald wrote addresses some of those nicely, and in particular, it's how to integrate all these different forms of therapy. But certainly for the PAD patient, I'd say even more so, where there's a huge unmet need, I think this really provides an advance for the care of those patients, where not just coronary events were reduced, but things like amputations were reduced.
The history of cardiovascular medicine in the last 20 or 30 years has shown that when a concept works, ends up being there. I still remember left ventricular assist devices. Remember, the results were very borderline.
Right.
And this is not going to work. It's very expensive. We'll never make. And you can see how this all advances. So, but anyway, and thanks very much for reminding me. You were one of the authors of this paper, as on many of the studies, Deepak. But I think it's a very interesting study and will give us a lot of thought. A few years ago, we thought the antithrombotic field was over, and now it's going up, exploding. So
It's probably the best message, that there's still room for improvement along multiple axes, along the inflammation axis and even along the thrombosis axis. So that's exciting.
what we are learning, I think, is that each of these antithrombotic agents, of course, there's this antithrombotic problem and the bleeding problem. But each agent, depending on the action, has more one than the other. So I think what we are learning is that it's not like you give more drug, it's going to be more bleeding, not necessarily. And this is a clear example how a low dose of a drug is not.
What is interesting is also we have been trying to shorten the dual antiplatelet therapy duration. And now we are coming and replacing one ATP receptor antagonist with anticoagulation, which is very interesting.
The events are different, though. If you compare it with CANTOS, the composite is driven mostly by a reduction in myocardial infarction. This is driven mostly by a reduction in strokes.
It's true.
So, it does kind of suggest, I mean, hypothetically, that there may be a different pathway of action with one versus the other.
But there are patients also with PAD, and they might have also problems with circulation, with cerebral circulation.
Or you could argue that this is a group of patients that would have a very high rate of silent atrial fibrillation, and you are giving an anticoagulant and you're preventing embolic stroke.
Though people forget, even in Pegasus, which was a remote MI trial with dual antiplatelet therapy, there was a statistically significant reduction in ischemic stroke. Even going back in time, Charisma, of course, you were on the Data Safety Monitoring Board. You'll recall in the overall trial, I don't mean any subgroup, there was a statistically significant reduction in ischemic stroke. So even DAP does have an effect there.
Well, you're getting too excited, and
I am getting excited.
look, let me tell you something. We have to move on here. So let's go into the study number 4. We have 8 studies, remember. This is an acute coronary disease, and I will be very succinct, and it's the whole question of ivalirudin versus heparin monotherapy following myocardial infarction. This is the so-called VALIDATE-SWEDEHEART, which was done in Sweden, a study in which basically the question is which one of the two is better. And this has been a very controversial issue. So in this multi-center randomized registry-based open-label clinical trial, the authors enrolled patients with either ST segment elevation MI or non-ST segment elevation who were undergoing PCI treatment. And they were treated in PCI with potent P2Y12 ticagrelor, prasugrel, or cangrelor, without the planned use of glycoprotein 2B3A. This is important, these little issues, and also the radial approach. Why? Because all the other trials in which these drugs have been used, this was not part. So this is a very modern approach to PCI in the acute coronary syndrome. I'd just like to go straight away into the results of this. We have the primary endpoint was the composite of death from any cause, myocardial infarction, and of course, mesh bleeding during 180 days of follow-up. At 180 days, the results, let me tell you, were exactly the same on everything. When the composite endpoint and with when you start separating each of them, and when you look at bleeding alone, there is not enough power to say one versus the other. So, Deepak, do you think this is telling you something about this? You participated in the other studies. What do you think?
Well, this study is very well done. These Swedish registry studies are incredible how they're doing randomized trials.
It's amazing, isn't it?
It's
great. Everybody there.
Absolutely, and as you know, with the ACC and AHA, we're trying to do similar things in the US, but they're years ahead of us. The results are believable. I mean, I think when you are going up without a 2B3 inhibitor, with good agents like ticagrelor in the background and radial approach, you know, it narrows a gap that would have otherwise been there. The older trials, when there are 2B3 inhibitors on board with the heparin, no question that bivalirudin reduces bleeding, especially from a femoral approach. But you know, I think these results are terrific. And you know, Adnan for years has been trying to tell me that there's no difference between the two. I've been disagreeing with him, but you know, it's a large, well-done study. It's hard to argue against it.
So Adnan, you were right.
Yeah, no, I think that we have been evaluating bivalirudin in different clinical situations, and if you don't use 2B3A inhibitors, you don't see any benefit. If you use 2B3A inhibitors, and it was, for example, the case of ISA-REACT-4 trial, you have a difference. Yeah. But now, as he said, with the new antiplatelet therapies, you don't need this strong antiplatelet or 2B3A inhibitors. And
not using the 2B3A, which was causing the bleeding on heparin, isn't it?
Right, yeah, the use of 2B3 inhibitors has really got.
So let me ask you, Borja, here is the question. I only see a difference between these two drugs, and it's the cost. So what will you do on the next patient that you're going to intervene?
Well, here in our center and in Europe, I think we were not using that much bivalirudin even in previous years. I think that this data is clear that there are no difference between the two of them when you are treating patients according to current standards. There is a role of bivalirudin for patients with heparin-induced thrombocytopenia. But I think what I like the most about this trial is that there is no sign of increase in stent thrombosis, because the previous trials there was a sign of increase. So I feel really relaxed about this result.
But you have also to take into account that more than 30% of the patients had heparin on board before going to have bivalirudin in this study here.
Yeah, it's not a pure
Yeah.
study. in a
Because
way.
this is also the practice.
This is what happened on the
These patients
registries,
get heparin
Yeah.
before coming to the cath lab. You cannot change this practice.
Yeah.
Real life.
Yeah.
Any comment?
Yeah,
Barbara?
no, I do what I'm told. This is pretty convincing.
Okay, well, you are saving time that we need today. Let's go into number 5. Now we are getting into atrial fibrillation. Dual antithrombotic therapy with dabigatran after PCI in atrial fibrillation. Yeah, we have the pioneer study recently, isn't it, which was rivaroxaban at a low dose. Interesting, which I couldn't understand. And here it is, with in these patients with atrial fibrillation with the platelet inhibitors. So here we have the question is, we face these patients, atrial fibrillation and stents. What do you give? Well, it's interesting, triple therapy or double therapy. What we are dealing here, these authors of the paper, Chris Cannon was actually the PI and presented the paper. It's called the Redual PCI. And here we have, again, with 2,700 patients with atrial fibrillation undergoing PCI. With triple therapy, I think it's important to realize that the triple therapy was 1 to 3 months. Warfarin plus the clopidogrel, ticagrelor, and aspirin. If it was a bare metal stent, was 1 month. If it was the other type of stent, 3 months. Later on, they go with dual therapy. So it's very important that we realize that these 3 versus 2 is very much at the beginning, in the first 3 months. And later on, they have we have dabigatran. 2 dosages are used, 110 milligrams twice daily, particularly in elderly people, versus 150 milligrams twice daily. And the patients were then followed, and the primary endpoint was certainly started with bleeding, because has been the problem with triple therapy, and then the composite endpoint of thromboembolic events, death, and revascularization. Now, what about the results? Well, the incidence of the primary endpoint, we are talking about bleeding, was certainly better in the dual group, 15.4% in the follow-up of 14 months versus 26% in the group that was triple therapy. This is when the 110 milligrams were used. When the dabigatran 150 milligrams was used, the bleeding was a little bit higher than before in the dual therapy, but not as high. It's 20%, and still in the triple therapy is 25%. Remember, the triple therapy doesn't have dabigatran, it's Coumadin, so are 2 different. So here we have the final results of this Redual study. Among patients with atrial fibrillation who had undergone PCI, the risk of bleeding was lower among those who received dual therapy with dabigatran and the P2Y12 inhibitor than among those who received triple therapy with warfarin, aspirin, and the P2Y12. So that's basically the results. It seems to me that we are moving into dual therapy on patients with atrial fibrillation and stenting, isn't it?
Yeah. We have 2 things to discuss here regarding this trial. One is the doses of dabigatran. I think that in looking at these results, the best doses is 150, because no one will accept to have a higher stent thrombosis rate for the sake of reduced bleeding complications. Because you see there is a almost 80% increase in the risk of stent thrombosis, which was not truly significant, but it's a very strong trend. On the other side, with 150, you don't have this trend in the increase in stent thrombosis. So for me, I would accept a little bit more bleeding, but having the safety of stent thrombosis, of reduction of stent thrombosis.
As you say, the composite endpoint was similar, though. The non-bleeding endpoint.
No, I mean for the specific endpoint of stent thrombosis with 110, it was higher than in the triple therapy group.
Yeah.
They're
The
also
second thing
older
I had,
patients.
I
They're
would,
older patients.
yeah, I would discuss is the lack of a group without aspirin, which was the case in the worst trial. So we don't know here whether with leaving out aspirin would have been also the same in the reduction of bleeding of the gate. Because if you look at the worst trial, the reduction of bleeding is even more dramatic with leaving out the aspirin as compared to the triple therapy group. These are things that we should still discuss and better understand.
I agree. We should be clear that aspirin was not used in the dual therapy. Aspirin was used in the triple therapy. I just want to say for all of us in the discussion. And then the other issue was that Coumadin was used in the triple therapy, while the Vigaton was used in the dual therapy. Any comments, Barbara?
It's a bit, all very complex and has been a very controversial topic in the guidelines of atrial fibrillation, and one ends up having a kind of consensus of what to do between two evils.
I always say the students, when they talk about dual antiplatelet therapy, and I say go to the European guidelines on intervention and tell me how you understand the figure there. I have to tell you, and I tell you have to be an Einstein to really understand what to do with dual therapy. It's very complicated. Isn't it?
It reflects the general sort of confusion.
But there is a trend, though,
Yes.
into dual therapy.
I think it's really important what you have discussed about the aspirin in the all arms, because most of the difference in bleeding seem to be at the very first 3 months, even though later there seem to be differences, but most of them, and later on, after 3 months in drug-eluting stent, they drop aspirin in the warfarin, and the curves are not diverging that much. So do you think this
But I
is
think the
critical?
message is actually pretty simple. The figure in that paper is very complex.
Oh, that's fantastic
Yes.
to really use your brain.
It's nice and colorful, but it's hard to interpret.
Yes.
But the message from Pioneer and now Redual is very clear that full dose aspirin, ADP receptor antagonist, warfarin with therapeutic anticoagulation is a bad strategy.
Exactly.
It causes a lot of bleeding. And here are the dabigatran 150 plus ADP receptor
And
antagonists.
the other rivaroxaban.
It looked good.
Yeah, I
And
think
the
it's
other
very
12 were
important,
positive.
getting rid of the aspirin and of the Coumadin and just working with dual therapy.
But I think Adnan brought up an important point. In doing that, it is important to not underdose the anticoagulant.
Yeah.
Here, the 150 is, I think, of dabigatran, the winning arm. The 110 provides some flexibility for patients that are very
Exactly.
frail or high bleeding risk,
Older people
but shouldn't be
and so-
used in a young, healthy person.
Yeah.
They're the
I
150.
agree, it's a
That's
good
right.
point.
Yes.
Let me go into the paper number 6. I will only tell what the paper is about and see what you think is the EMANATE study. This is a study presented by Dr. Exakovic, and basically it's patients with atrial fibrillation undergoing cardioversion. What is better, Coumadin or Apixaban at the usual dose? I think it's 5 milligrams twice daily. And the final results suggest that the best approach is using Apixaban. There were 1,500 patients here who were randomized. And I will say you the data of the 753 patients treated with Apixaban, there were no strokes. And of the 747 patients treated otherwise with Coumadin, I suspect heparin Coumadin anticoagulation, there were 7 strokes, 6 strokes. So that's basically the data. I am surprised, I must say, I am surprised to have 6 strokes on a cardioversion that is done properly by covering with anticoagulation. This was my...
I completely agree.
It doesn't...
It doesn't really reflect what is the practice. It's a very rare event, fortunately, and even previous studies have been criticized because they are underpowered to actually detect. So we are really very much in the play of chance here and bad luck.
What do you think, Borja?
I completely agree. So few numbers and not expected, so I would be very cautious about this.
Okay, so I think...
Well, I agree, but practically speaking, maybe there isn't superiority, but even if it's as good as, it's a simpler strategy, other than the cost
I
issue.
agree
Do
with
we
that.
know?
Practically we can
We don't
use...
know.
So it's I think that the future of oral anticoagulation, of the conventional oral anticoagulation, is not bright anymore. Right. And it should be replaced.
Yeah, but
Yeah,
yeah, and I agree.
all indications.
Practically speaking, you know, you give this anticoagulant and it's acting right away. You don't have to go through the heparin and the coumadin and so forth. Well, anyway, we have 2 studies left, and one is pretty hot actually. It's the spiral hypertension. Deepak. Yeah, you did the original one, and you were the first to be surprised. It didn't work. We are talking about sympathectomy in trying to address hypertension in people who we call are resistant to 2 or 3 antihypertensive medications. I'm going to make this paper very short in terms of the presentation. This was presented by Michael Baum from Hamburg in Germany. And the first author of the paper that came in the Lancet is Dr. Raymond Townsend from the University of Pennsylvania. And this is an interesting study with 21 centers in the United States, Europe, Japan, and Austria, where they actually look at people with significant hypertension. I don't have to go into define exactly the figures here. The total number of patients, actually not large number, frankly, 80 patients.
Yeah.
So they had a tough time in the recruitment aspect. And 80 patients that were appropriately randomized into a sham control approach in a very complete renal denervation. This is a difference with the original study in which there were questions about how the technology was actually looked at. And just to make the long story short, there is a difference in blood pressure, systolic, diastolic, and mean. But the difference is about 5 millimeters, 6 millimeters of mercury, maximum 10 millimeters of mercury. And I'd like to ask you, Deepak, how do you react to this study? Small number of patients, certainly there is a concept that appears to work, but again, the results are quite...
Sure, so your caution is very well advised. It's only 38 patients that got the denervation. The trial was stopped early at 80 instead of 100 patients, so have to be cautious about the results. But, you know, much like Simplicity 3, it is sham controlled, so I believe the results. So I think it does show with this newer catheter with multiple electrodes, more aggressive denervation, the concept works, and that validates what we already knew. Surgical denervation works from the 50s. If you completely denervate, blood pressure drops. The real question is this degree of blood pressure reduction from an invasive, expensive procedure worth it? But I think it's sort of like the inflammation study. It opens the door again here that maybe better catheters, better techniques may be clinically worthwhile. Here, this is a very, very modest effect, so I think if we were sticking with this technology, it would need to do better. There need to be further iteration of it. But there are multiple other competing technologies for blood pressure, invasive technologies, that if they can take this concept further with more complete denervation, that might be a real win.
Borja, how you react to this paper?
Well, I agree with Deepak. I think the concept is good because renal denervation reduces blood pressure. We don't know how much. Also, these patients are different from the other trials because they are moderate hypertension. They excluded those patients with very high blood pressure levels. I don't know to which extent this might also have an effect in those who are on treatment and still they are not achieving the goal. So, encouraging, but still this is too preliminary.
Yes, I agree. I mean, they had to withdraw the drugs in order to show these small effects. If there is a place for this technology, is in patients with resistant hypertension and multiple pharmacotherapy. Otherwise, a reduction in 5 millimeters of mercury on ambulatory blood pressure, as they showed here, can be achieved with a run-of-the-mill antihypertensive agent.
You think the recruitment was low because of the previous study? What is your feeling? Because they really, you know, they went from, it was a period of time that was significant in my view. It was June 2015 to January 2017, and you're dealing with 21 centers.
Yes.
So the question is why?
Well,
the
you know,
recruitment.
these patients aren't on medications, right? So,
Yeah.
I mean, in real life, you just
Well, it's
start
not
a generic
resistant
diuretic.
hypertension,
You
that's
wouldn't
not.
send someone to an invasive procedure.
Yeah.
I'm surprised that so many patients did agree.
Really?
Yeah.
It seems that
Because
Well,
this kind of patients
didn't
it's,
want to
yeah.
take medication. This is why
And
they
to
were
have
willing to be enrolled in this.
ablation in 5 different branches of
Yeah.
it's too much.
On the
Yeah.
positive side,
For this kind of patients. yeah.
you don't need to be an expert to find an effect, because with 21 centers and 80 patients, none of the centers actually
On the other side, I
did
think
some.
that this trial may open the door to the device versus device trials. Because if here it's thought that, that the device is bringing the result, there are so many devices available, and
That's a really good point. You
Yeah.
know, the other thing too, I'm a little nervous that it may cause too much of a resurrection of renal denervation. That is, I think this is a good proof of concept scientifically, but it doesn't negate the prior uncontrolled, unblinded studies that we're seeing 30 millimeters
Yes.
Yeah.
of reduction, right?
Yeah, that's
Those are definitely spurious results.
Yeah.
Yeah.
So here in this carefully selected patient population, not on any medicines, there's a, you know,
Yeah. But
mild effect.
ambulatory blood pressure never showed the significant results, even in the simplicity trials. So here, at least, we have a reproducible measurement, robust reproducible measurements of blood pressure.
That's
So-
what's exciting. There's
Yeah.
something here, and it might be other competing technologies that really take this over the goal line.
Okay, we have 5 minutes, so we are on time. Final, oxygen. So Borja, you tell me what the guidelines say about, I want to give you a bad time. What the guidelines that came today say about oxygen and myocardial infarction?
It was very good that we had access to this data before the guidelines, so
Oh,
the
no.
guidelines are
Now you,
That's not fair.
I was so looking forward these last few minutes. You
Spoiled
came
it.
prepared.
look at the data.
No, still we had data from the previous trial that was the AVOID trial. The
Yeah.
primary outcome was infarct
Yeah.
size.
We
The
actually
threshold was
discussed.
93% and no difference. So
Yeah, what is interesting about this, well, let me, this is entitled Oxygen Therapy in Suspected Acute Myocardial Infarction, again from Sweden, the talks Sweetheart investigators. And basically this paper that came up yesterday also in the New England Journal, Robin Hoffman from the Karolinska Institute is the PI. And what they did is 6,000 patients were enrolled in the study. And the question that comes in the guidelines is you should give oxygen if there is hypoxemia, but it has not been clear if you should give oxygen to everybody. This is really the guidelines until yesterday, so, which is interesting because anyway, it's hard to understand how this works. The way oxygen is supposed to work is you are giving oxygen to the heart. You know, when we talk about oxygen, you think about the lung, isn't it?
Yes.
Here is the heart, it's just the coronary artery down there. And I don't know how the oxygen gets there, but most of the people are not, they don't have a hypoxemia. In this group, actually, 7.7% had relatively hypoxemia in the overall, in the group that was not on oxygen. And in the group that was on oxygen, 1.9%. But the bottom line here is they look at the primary endpoints, which was death from any cause, and then rehospitalization with myocardial infarction 1 year later. There was no difference between either giving oxygen or not giving. And actually the comments being made is you still have to give oxygen if there is hypoxemia, but otherwise you really achieve very little. So I just like to ask your opinion about it. You're pretty cool today, though. You look at and then you make it, and then we are all surprised by your comments. So what do you have to say about oxygen?
Oxygen. I was part of the task force for the guidelines, so nothing more than.
So you knew the data before it came out?
We knew the data. We knew our practice, which was not based on oxygen. Also, before knowing this data. So
we
we didn't treat patients with
We
oxygen.
learned with the
yeah,
ABIT study before that,
Yeah.
that came out. So
Yeah, well,
any comments?
Yeah, no, I think, we learned it, people that are looking a lot at the data, but it's still a very common practice.
Yes.
You show up in the ambulance, you show up in the emergency room, the first thing the EMT
There's no
tech or the nurse
question.
does is put oxygen
Yes.
on. So I think it's an important study because hopefully it'll change practice to what common sense says. If the person's not hypoxemic, no need to give them oxygen.
Well, the
And-
problem, but the problem is not by deficit. The problem is that this oxygen can cause troubles, and we all know there's a good literature about
Yes.
it. So it's not something that you should not do because it doesn't do
That's right.
anything.
Exactly.
Yeah.
In fact, in the new guidelines, to give oxygen when the saturation is above 90% is a class 3 indication. So it's not recommended to give oxygen.
Mustn't do
This
it.
is the reason, oxidative stress and lots of things happening. So on that, so
Yeah.
we have made it. We made it. All of these eight most important studies. We believe there were others, of course, and maybe final minute. I'd like to go around what you people like the most of what you have seen of these 8 studies. Borja, what do you think? Which one you think you are most?
If I had to choose one, I would choose the COMPASS, the rivaroxaban data. I think this is pretty convincing, especially the reduction of cause mortality.
I'll choose CANTOS. I think I like a new horizon, the testing of a scientific hypothesis. For me, intellectually, is a very attractive study, and the side effects of a 70% reduction in lung cancer is
It's
awesome.
very striking.
Yes.
No,
So-
for me also both CANTOS and COMPASS also, because maybe this is the sign of the start of post-device era in the coronary artery disease. So we have been talking before about bioresorbable stents and other kinds of stents. If you look at the hotlines this year, there are no device trials anymore in the coronary field. So it's dominated by drug trials, which might be a good sign for the future.
Coming back, actually, is indeed, because it was a period, was very pharmacologically oriented, still, but it seems it's going up. I think one of the most exciting issues, though, is people are getting more and more into the risk factor profile. And I think there's a lot going on imaging, genetics, and identifying people with subclinical disease. And I think this pharmacological era is also is within the context of trying to change behavior and risk factors at the same time.
Well, I agree with what's been said. COMPASS, I think, will change practice. CANTOS changes the field. But just to say something different, I'll say Redual PCI, because I think that shows that aspirin, a ADP receptor antagonist, and full-dose anticoagulation with warfarin, or I think anything else, is a bad strategy. We didn't mention, but there was actually an excess in intracranial hemorrhage with that strategy.
It's nice
So
to
it's a
comment on.
bad strategy. And in older patients, 80-year-old patients, triple therapy like that, very, very bad.
Well, exactly, I think it's exactly 1 hour. And you were fantastic. I really think it was very good. Very nice conversation and dialogue. And as we said at the beginning, this is a very relaxing time for all of us. We all understand the fields, more or less what is going on. We deal with patients every day. We deal with clinical investigation and with trials. And it's nice to have different points of view together and discuss, as we have done today, the 8 subjects. So if I have to pick up the number 1 subject, you.
Number 1 subject.
Yeah. Subject means people in this case. You have done very well. I feel so happy about it. I think we have discussed everything in the best way we could, and you really have done fantastic. So I'd like to say this, to me, is the most important of all the 8 subjects. This one added, it has a human soul. Anyway, for the audience, thank you very much for listening, and I hope we will be back on the next meeting. The next meeting will be with American Heart Association meeting this year, and we will continue. Thank you very much for listening to us and for viewing us. Thank you.